Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the diabetes insipidus. So first of all, I'll go to the definition. So how can I define diabetes insipidus? What is the definition? It is a clinical condition of polyuria and polydipsia due to lack of production of antidiuretic hormone, also called vasopressin. Okay, it is a clinical condition of polyuria and polydipsia due to lack of production of ADH or unresponsiveness of the kidney to the antidiuretic hormone or vasopressin. Same thing, vasopressin. Okay, we got the definition. Then we have to know site of production of antidiuretic hormone. Site of production of antidiuretic hormone. Site of production of ADH. Okay, it is produced from the supraoptic nucleus of the hypothalamus. Site of production. Then we must know site of action. This hormone acts on the blood vessels, but its most important function is it acts on the collecting tubules of the nephron, also the distal convoluted tubule of the nephron. Okay, so collecting tubules of the nephron and distal convoluted tubule of the nephron. Distal convoluted tubule of the nephron. Okay, we got site of action, site of production. It is produced from the supraoptic nucleus of the hypothalamus, but it is stored in the posterior pituitary. Idea is that, so if this is the brain, okay, this is the thalamus here, this is the hypothalamus, then we have the posterior pituitary here, anterior pituitary here. From the hypothalamus, axon end goes to the posterior pituitary gland. Okay, through the pituitary stalk. This is the hypothalamus, the thalamus of the brain. This is the posterior pituitary, the pituitary stalk. So this is the axon of the hypothalamus. That axon end up here. So posterior pituitary is the storehouse of the antidiuretic hormone. It is not the cytoproduction. Okay, so cytoproduction is the hypothalamus. Cytoaction is the collecting tubules of the nephron. Nephron is the structural unit of the kidney. Each kidney has around 1 to 4 millions of nephrons. So we got cytoproduction, cytoaction. Okay, now we'll go types of diabetes insipidus. Okay, types of diabetes insipidus. Types. What are the types? One is the neurogenic type. Okay. Another one is the nephrogenic type. Nephrogenic type. Neurogenic type is due to the damage to the hypothalamus, or maybe in the posterior pituitary domains. Okay, due to damage to the posterior pituitary, we may have neurogenic type of diabetes mellitus. If we have problem in our kidney, especially renal medulla, we have non-responsiveness of the ADAs to the distal convoluted tubule and the collecting tubule, then we will get the nephrogenic diabetes insipidus. Okay, so what are the signs and symptoms? Signs and symptoms of diabetes insipidus. We'll get polyuria, that means increased frequency of micturition. People go to the restroom very frequently. Okay, polydipsia. Okay, this happens due to dehydration. Okay, and people is losing urine and people become thirsty, so they are taking too much water. Okay, so got polyuria, polydipsia. Dipsia, we may have electrolyte imbalance. Electrolyte imbalance. Okay, even we may have seizure or headache. Seizure or headache. Okay, that is possible. Okay, so, and certainly people may not like to go to the restroom so frequently. They may be very nervous. Okay, so we got the signs and symptoms. Okay, and headache. Okay, polyuria, polydipsia, electrolyte imbalance, seizure and headache. Mostly polyuria, polydipsia. This may happen. Okay, usually people take a lot of water, so they may not go through these problems, electrolyte imbalance or seizure or headache. Okay, we got signs and symptoms. Now we'll go to the etiology, causes. Etiology. That means causes of diabetes insipidus. So again, neurogenic cause. We have neurogenic. It may be idiopathic. We may not know the cause. Okay. It may be due to trauma to the brain or to the hypothalamus. It may be due to tumor of the brain that disturb the function of the hypothalamus. Maybe due to infection like tuberculosis, meningitis, sarcoidosis. Okay, so that may happen. So any intracranial pathology, we can say any intracranial pathology, okay, we may get the neurogenic tumor. Yes, tumor may develop inside the brain. It may be primary tumor. It may be metastatic tumor from the breast or from the lung, may go to the brain and disturb the hypothalamus. Okay, So we got that. It may be autosomal dominant condition, genetic disorder, autosomal dominant condition. Okay, that may be possible. Okay, so these are the causes of neurogenic diabetes insipidus. Now we'll go to the nephrogenic diabetes insipidus. Nephrogenic. What are the causes of nephrogenic diabetes insipidus? Nephrogenic diabetes insipidus. What are the possible causes? Okay. We may have renal medullary disease. Okay. Disease of the medulla of the kidney, medulla of the kidney. Okay, that may disturb the counter current mechanism and the osmolarity of the interstitium and the medulla. That may be a problem. Okay, it may be like that of pyelonephritis. It may be due to polycystic kidney disease, polycystic kidney disease. Okay, maybe due to polycystic kidney disease. Okay, so or it may be a complication of sickle cell anemia. Sickle cell anemia. Okay, that is a possibility. So there are many reasons for nephrogenic diabetes insipidus. It may be caused by drugs. Okay, so drug induced. That is possible. A lot of drug may lead to nephrogenic diabetes insipidus, like that of lithium, a commonly prescribed drug for bipolar disorder. People has depression followed by mania, again depression followed by mania, and due to bipolar disorder. Okay, lithium. Due to intake of tetracycline. Okay, antibiotic tetracycline like democlocycline. Okay, tetracycline, that may cause that problem. Okay, an antifungal drug, amphotericin B, amphotericin B. Okay, so some type of muscle relaxants, especially used in case of anesthesia. Okay, or it may be due to electrolyte imbalance like hypercalcemia, hyperkalemia. Okay, hypercalcemia, hyperkalemia. Okay, this may happen, and it may be a X-linked disease, chromosomal disease, X-linked recessive disease. Okay, that may be a possibility. Okay, we got that. The causes of nephrogenic diabetes insipidus. Okay, what are the possible differential diagnosis? What are the possible differential diagnosis? So, differential diagnosis. Okay, it may be due to, people may consider as diabetes mellitus. Okay, it may be type 1 diabetes in the young age, in the late age, type 2 diabetes. Okay, due to primary polydipsia, primary polydipsia, okay. So that may be a manifestation of diabetes insipidus differential diagnosis, okay. We got that. So we got differential diagnosis and some type of nephropathy that may lead to polyuria, nephropathy, any type of nephropathy, or abuse of diuretics, okay. Abuse of diuretics that may also lead to diabetes insipidus like feature polyuria, polydipsia, or it may be psychogenic. Okay. Differential diagnosis, we can take it out very easily, okay. First of all, diabetes mellitus. If we go through fasting blood sugar, we'll find out whether diabetes is present or not, or glucose tolerance test, okay. We can easily diagnose diabetes mellitus. Primary polydipsia, we may go through the water deprivation test. Nephropathy, we may investigate and find out or test something to find out any kidney disease. Abuse of diuretics, we must get the history properly, watch, observation, okay. Psychogenic, again we can ask the question why he has to go to the restroom so frequently, okay. We got that. There are many differential diagnoses depending on, we'll go through the clue of polydipsia, polyuria, like that, okay. So what are the workup to diagnose diabetes insipidus, okay. Workup. What workup is essential? We find out the urine analysis, okay. Whatever urine in diabetes insipidus, almost like water, no odor, no color, okay, and no smell, almost like water. People are taking too much water, so that they take out all the water, okay. So analysis, so it will be low osmolarity, specific gravity is almost like water, okay. Specific gravity. There is no sugar in the urine because it is not due to diabetes mellitus, it is not due to 180 mg% glucose in the blood. Then we get glucose in a patient of advanced diabetes mellitus, okay, because there is a renal threshold, will not go there, okay. So specific gravity, this, and urine analysis, and we'll also look for electrolyte study. This person may have hypernatremia, okay, excessive sodium in the system, that is a possibility, okay, hypernatremia. So we'll go through water deprivation test, okay. If you deprive the patient for several hours, we'll assess the blood osmolarity and urine osmolarity. Then if we give the person antidiuretic hormone like substance injection, then in case of central diabetes insipidus or neurogenic diabetes insipidus, urine concentration will be increased, there will be high osmolarity, and specific gravity will go up due to concentration of the urine in case of neurogenic diabetes insipidus. But in case of nephrogenic diabetes insipidus, it will not respond because the site of action of the antidiuretic hormone is defective in the collecting tubule and the distal convoluted tubule, okay. We have gone through that. If we suspect something wrong in the brain, then we can do an MRI to find out any problem in the hypothalamus or something blocking the posterior pituitary or if you get a history, person may have previous history of some type of tumor removal like that of craniopharyngioma or pituitary adenoma. In that condition, posterior pituitary may be damaged and the person may have initial few days or few months he may develop diabetes insipidus. Okay, because there is the storehouse of the antidiuretic hormone or vasopressin. We got that? So we can do urine analysis, electrolyte, water deprivation test, and MRI of the brain. Of the brain and head, okay, you can say to the head MRI will work better. Okay, very good. We got the workup. Now we'll give the treatment. Treatment is very easy to remember, especially in case of neurogenic diabetes insipidus. Okay, we'll find out the exact cause, and as because there is lack of production of antidiuretic hormone or vasopressin, we'll give this person synthetic antidiuretic hormone. Okay, in case of neurogenic treatment, okay, we can call it management. Okay, treatment should be given by a registered physician. Okay, management, we can say how it is managed pharmacologically, what drug is given. Neurogenic diabetes insipidus, it should be treated by means of the synthetic ADH. Okay, synthetic ADH. Okay, like DDAVP. Okay, we can give that DDAVP, synthetic ADH. It may be given intranasally, may be given intravenous, depending on the situation. What is the treatment or management for the nephrogenic diabetes insipidus? Okay. In nephrogenic diabetes insipidus, it is managed by hydrochlorothiazide. Okay, so there is a diuretic. How it works in the management of diabetes insipidus, the exact mechanism of action is not very clear, a little bit elusive, but the idea is that the thiazide diuretic is very essential in the management of nephrogenic diabetes insipidus because it excretes sodium. Plus it also helps in the reabsorption of the glomerular filtrate from the proximal convoluted tubule. So sodium excretion plus reabsorption of glomerular filtrate from the proximal convoluted tubule of the nephron, it works, and it may decrease the urine output from 11 liters to 3 liters. Okay, so that is the management. Idea is that we also give the patient about health education. They should take plenty of water and they should take less sodium. Idea is that this person has hypernatremia, so low sodium diet and plenty of water. This is very essential in an obtunded patient or patient in incarceration or in hospital admission. So it is essential to give the person health education. Okay, so that's all about the diabetes insipidus. If you like my video, please subscribe my channel, support my channel, and share the information with your friends. If you have any question, please feel free to ask me. So have a nice day or a nice night. So thank you very much. Thank you. That's all for today. Thank you.